Thank you for that very kind introduction, and a very interesting talk that preceded mine. And everything you say, I actually agree with you. However, my research is really involved in people, and you're absolutely right. We do not really know, but what we have is observational research. And these are women that actually have taken the medication, and so we have to follow them up. And it would be great to do studies like the animal studies, but unfortunately it's not going to be possible. And before I start, I just wanted to mention that it's not really my opinion. I guess it is my opinion. What I feel is that it's not that we don't, a lot of people say, oh, there's no information on drugs in pregnancy. But however, there's a lot of information, and I think the problem is how it's being disseminated. And this is really what I'm going to talk about. And this is what I did my PhD defense about. Now, I'm not sure if in Turkey you're familiar with the terminology knowledge transfer or implementation science. Is anybody familiar with that? So it doesn't seem like anyone is, but I think it's going to come to you, because I think it's all very well to do the research, but then we have to understand it and disseminate it properly so people will be able to make evidence-based decisions, especially for me is taking drugs in pregnancy. So this is what I'm going to talk to you today about knowledge transfer and translation of research findings from studies, and I'm going to specifically talk about antidepressants in pregnancy. Oops. Am I doing the wrong one? Sorry, am I doing the wrong one? I'm so old, I'm still not very technologically good at this stuff, even though I've done it lots of times. Oh, this one. I pushed every button except for the correct one. There you are. So my esteemed colleague there mentioned thalidomide, and of course thalidomide really started this whole field really about teratology, because up until then, surprisingly, we were very ignorant about it. In fact, right up until the 1950s, even when I was born, people used to think that drugs didn't cross the placenta. For some reason, there was a barrier, and you could do anything you wanted, and it didn't cross the placenta. But when we found out about thalidomide, then we realized this is not true. And unless it's a very huge molecule, pretty much everything goes across the placenta when a woman's pregnant. So, but and we're certainly in the big information age today. Everybody knows everything today, and everybody knows everything from the internet. So even those days, it became the thing to tell everyone that women shouldn't take these medications when they're pregnant, because everybody thought there was going to be another thalidomide. And I can understand that. However, as I'm going to explain to you a little bit further, there is really a lot more information than what you might think about the safety of drugs in pregnancy, and especially antidepressants. And you may or may not know that out of all the drugs in pregnancy, antidepressants has the most information. In fact, to date, now, we have information on about 150,000 cases of women who took antidepressants in pregnancy with outcomes. So we know what happened to the baby. So that's observational research. That is real life research. Okay, it's not controlled in a lab, but it's what happens in real life. And I think, everybody knows that's post-marketing surveillance, and that's what we have. I mean, we're not ever going to be able to do randomized controlled trials in pregnant women. So we have to use this evidence. But a lot of this evidence is not really understood, or people don't know about it. So this is why I felt this was very important to explore this whole thing about disseminating information. So, you know, there's mostly many psychiatrists in here, so I think most people know that we don't know exactly the rate, they vary, but about 10 to 15% of pregnant women are diagnosed with depression. And it's not always feasible to not to take the antidepressants when you're pregnant. And I think anybody knows that most antidepressants should not be taken abruptly. They need to be stopped and tapered off suddenly. And we know now that half of all pregnancies are unplanned. So very often the woman is already pregnant and she's already taken the antidepressant. So it's not very valuable to give her information saying you mustn't take this antidepressant because her baby's already been exposed to it. So this is why, for me, I started doing all the research that I've done on looking at the safety of antidepressants in pregnancy, because in my line of work, we have 35,000 people call us at the Mother's program at the Hospital for Sick Children in Toronto, and about 15% of them call about psychiatric drugs. So it wasn't just enough to say, well, sorry, you shouldn't take that, there's no information, bye. So we felt we had to do the research. And because of my background in psychiatry, I took it upon myself to study as many of the psychiatric drugs as I could. So obviously this is a new thing for you. Are you familiar with it, August, the knowledge transfer translation? Because nobody sort of nodded when I mentioned about it. Oh, you can't hear him. Were you familiar with the terminology?
Nazan is telling me that it's not really a familiar terminology in Turkey, whereas I am a little bit familiar, but thanks to you, I heard it first from you. So.
But I think that you'll find it's important because it's becoming worldwide, and I know in Europe it's very, and I think it's in my talk, so I think it's a very important thing because it's not just what the research is, it's how it's transferred and how it's translated to the people who need it. And Canada actually, and normally we don't really lead in the world because we're just a little country compared to the US, but in this particular instance, Canada was the one that really started this focus on the knowledge transfer and translation. I know in Britain they call it implementation science. It's just another terminology for the same thing. So this is how it's defined. The exchange, synthesis, and ethically sound application of knowledge within a complex system of interactions among researchers and users. And what that really means is that from where the research is made to the end result of the patient who needs it is really, it needs to be, all these gaps need to be closed. And there's many barriers, and as you can see them on the slide. So my main objectives in talking today is, one, we think about this systematically. So first of all, we think about how is this knowledge created? So that's the first thing I'll talk about. And secondly, and what are all the different kind of models that are used to conduct this research? And thirdly, is to identify how the information is currently disseminated and how we can improve this. So these are the current, as I said, this is observational research. So we cannot go and get a group of women and say, okay, you 100 women are depressed and taking antidepressants, and you 100 are not, but you are depressed but not taking it. We don't have that. Unfortunately, we don't have the lab to do that, so we have to use what we can. So this, right now, these are the current models for studying it. And as you can see, I started with the lowest evidence and I sort of worked my way up there. And this is where we get the sources from. So patients' charts, insurance claims, physicians' practices. In the US, they have a very big database that is used a lot for studies. And at the bottom is where I come in from the Motherist program. The Motherist program belongs to a group called Teratogen Information Services. And there's a group in North America, and there's also a group in Europe called ENTIS. And you can look them up online if you want to see more about them. So first of all, case reports. So a case report is what we call a signal generator. So it can identify, so somebody, in the case of pregnancy, a woman is born with a baby that has a malformation and they took a drug, so they think, oh, I wonder if it's a drug. Of course, everybody always does think it's a drug, because that's more exciting and it's more likely to get published. However, there's always a limitation because it's just a one case. But it does start thinking, and this is what happened with thalidomide. And thalidomide was the most important case report ever for teratology. And this is one of my favorite slides. So as you can see, this is from December 1961, and this was the doctor from Australia. And actually, missing arms and legs is really quite rare. It occurs in like 1 in 50,000, or no, even more than that. I forget the actual numbers. But he had seen women having babies, and it was really with a 20%, which is unbelievable rate of these abnormalities. So he sent it off to the Lancet, and this is how the thalidomide started. And then afterwards, people, because they read it in the Lancet, and this is why case reports, you know, they aren't definite, but they definitely help. This is how we knew that thalidomide was a teratogen, because when people read this in the Lancet, other reports came from around the world, and then we realized this really was a major teratogen. Now, this is what we do at Mother Risk and Teratogen Information Services. Most of my studies that I do are called prospective comparative studies. So we're fortunate at the Mother Risk program, because we get so many people call us, the women actually phone us up themselves. So they ask a question, you know, is this drug safe to take when I'm pregnant? Because that's what we're there for, to answer their questions. So if we don't know, or we're interested in doing a study, we say, well, would you mind if we call you back after you have the baby to find out, you know, what happened? And this is true naturalistic observational research. So as I mentioned that already, so we only use women who are currently pregnant, because, as you can imagine, retrospective cases are rather biased, so we don't have anybody that calls, but pretty much everyone calls us while they're pregnant anyway, because they get very worried and they're anxious, and they want to know if what they're taking is going to harm their baby. So we're also fortunate with having the thousands of women that call us that we're able to form a comparison group. And so we usually have, in the case of antidepressants, we usually have another group of women who have taken a different antidepressant. And then we have a group that we call a non-teratogen group. And these are women that, most women, I must say, that call these services. And I think it's all because there's so much influence now from the media and their friends and the internet, and everything is, you shouldn't do anything really if you're pregnant, really. You shouldn't even walk outside the house, something could hurt your baby. I'm sure, you know, you've all heard that before. So most of the women call about things that really are not a concern. But they're great for our control group. So these are the women who, everything's the same as the women who are taking the antidepressants, except they're not on an antidepressant. So it's rather convenient for us, because these are not easy studies to do, I can tell you. So we match all the groups of women for year of birth plus or minus 2 years. And we also ask them questions. When they phone us, we have quite a long questionnaire which they fill in. And so we have a lot of information about them. So we match them for smoking and alcohol. And also, because we also don't just look for malformations, we examine other outcomes like miscarriages. So here's our primary outcome is usually, obviously, the incidence of major malformations. And our secondary outcomes are rates of live birth, stillbirth, spontaneous and therapeutic abortions, and also mean and standard deviation of gestational age at birth. So we want to know if these women have deliver prematurely, and also the birth weight. So because this is observational research, of course there's many limitations. But we feel the strengths of this type of study is because we do have a personal interview with the woman. So we take a very detailed history, as I mentioned already, and we only use it prospectively enrolled people. So also, if you're familiar with the evidence-based research, this kind of research is considered level 2 evidence. And it's really about the highest you can go with observational research, because we can't really do anything else to make it higher than that, because it is what it is. That's what I say many times, it is what it is. And we do the best we can. And also, most of our studies are pretty small, which is also a limitation. So it only has an 80% power to detect a 4-fold increased risk in major malformations. So what we really need is 800 cases to be able to detect just a 2-fold increased risk. And if we're looking for a really rare defect, we need thousands and thousands. So that's when we go into the case control studies, which I'm going to talk about in a minute. And again, the limitations, obviously, this is not random. These women call our line, so they are not the same as every woman out there. Usually they're more educated and they're more motivated. So, as I say, we try to do the best we can. So then I mentioned about case control studies. So that's the opposite of doing what we do at the Mother's program. So you start with the outcome first. In the other one, we start with the exposure. This, you start with the outcome. So say you have 100 women who had babies with spina bifida, say. So you look and see if they took a drug in common. That's an example. And again, the strengths in every study, the strengths and limitations, and it's very important that we understand them. So the strength is the ability to examine multiple outcomes. So as I mentioned before, you need far less cases to find rare occurrences. But as the opposite from my studies, these have a retrospective bias because the baby's already been born and we know the outcome. And nowadays they have pregnancy registries. So these are often run by drug companies, especially in the US now. In the US, the drug companies now the FDA expects the drug companies now to have these registries. So they have to run them. And so everybody's trying to be to their best, but they don't always have comparison groups. So you have to look at the limitations. So they can be really large numbers, but you don't really know some of the confounders, and also if they smoke or they drink, those sort of confounders either. And database registries, we don't have them in Canada because we have socialized medicine in Canada, but you know in the US that they have their healthcare. They have these huge organizations, and their administrative databases where it's for payment, actually, to get payment. So, and they have a lot of pharmacy records. So that's why a lot of drug studies are done from these registries. But again, these have their limitations also, because there can be missing data and errors of entry. There's so many thousands and thousands of them that it can be some errors. And also, this sounds counterintuitive, but remember I said in the beginning that our studies have small sample sizes. Well, these studies have huge sample sizes, and sometimes the sample size can actually be too big, and you can find false positives. So it can be a bit confusing sometimes. So you can find, and I'm going to talk about this in a minute, because this is where a lot of the information you see that's published on the internet or even in the medical journals makes a lot of these statistically significant results, and I'll go into it a little bit later. A meta-analysis. And my husband has kindly accompanied me here, and my husband's a he taught me a lot, actually. I have to admit it. Don't really like to, but I have to admit it. He taught me a lot about, he's a statistician, he's a pharmacoepidemiologist, and he's sort of a guru in the field of meta-analysis, and he started doing these meta-analysis for our small studies at Mother so he could put them together. And this way, when you have small studies, you can put them together and you can get much more, bigger numbers and more definitive results. So it does increase the power, but if you look at the bottom line, like everything I talk about has strengths and limitations. If you don't remember anything I say today, when you look at studies, you have to always remember, you must never take them at face value. So he always says, garbage in, garbage out. So if you don't include good studies in your meta-analysis, you're not going to get good results. So how much time have I got?
20 more minutes.
Oh, okay. So the next important part is critically evaluating the literature. Now, I'm sure all of you here read the literature, don't you? Yeah. And I'm sure most of you just read the abstract, and you don't be embarrassed. I mean, I think we have so many, there's like 20,000 something journals now, and nobody can read everything. So now they have, I don't know if any of you, probably nobody here does observational research, so you might not have heard of the strobe, but many of the big journals now require this, that you fill in this strobe before they'll even send your paper out for review. So it's a checklist of items. They've tried to make it, as scientific as they possibly can, In the absence of RCTs, they're trying to make it as strong as possible by requiring this. And then everybody knows what odds ratio is. And this is a term that's misused quite a bit. So odds ratios, they tell you, like if something, so if you have two groups, and if they're both the same, your odds ratio will be 1. So if one group has more differences than the other, then it's going to be more than that. So a lot of odds ratios you see, especially in the pregnancy studies, you'll find little maybe 1.5, and my husband, who's an epidemiologist, will tell you that if it's less than 2, really doesn't mean that much. So you have to tell yourself, just because it's statistically significant, does it really mean that it's clinically makes sense? Does this really make a difference? And also you'll see in the abstracts, you'll see the 95% confidence interval. Because 5% of it we don't really know what happened, why it happened. But this also can be used. This should be looked at when you're looking at the results. And you've probably heard the term, the logistic regression. But we don't normally use that much at Motherist because we pretty much try and match for everything. But some studies, they do use it. They don't have all the points that they want. And I mentioned also that probably most of you only read the abstracts, right? Yep. So, and that's okay. Like I said, it's okay. I personally don't read more than the abstract. If I don't like the look of it, then I'll read the whole paper if I think something's missing. But that's why you have to understand how to read abstracts. I know it just sounds like a new thing, but it's really true. It's really important. And also today they've reduced the number of words quite a bit. A lot of abstracts are only 200 words now. So they need to contain as much information. And if you don't feel right about what they're saying, then you definitely should read the paper, the whole thing. But I mean, if you feel comfortable, which I'm probably 9 times out of 10, I can sort of get what I want from the abstract, then honestly, I don't have the time to read them all. And we did a survey on evaluating abstracts, and we found a lot of the quality and content of them. We found a lot of items were missing that we feel were really important. I'm not sure if I should just skip the next few. This is just examples. What do you think, August?
I think it's really interesting that you show us your analysis of several abstracts. I find it personally very interesting.
Oh, okay. So yeah, I've given a few examples, because I always feel just to sort of tell somebody, it doesn't mean as much as if you give an example. It makes sense. So I picked a few. This is an example of an abstract. And I get very upset about it. I'm very passionate about this, so when I see stuff like this, I get pretty upset. And I've written quite a few letters to editors in my time. And most of them have been published, so I'm happy about that. But this one here, as you can read it yourself, so it would look like there was nearly 3,000 women in this study. And they look at all the risks. Look at this. Remember I talked about odds ratio. Here we are, 6, nearly 7, which is like, whew, that's a really big risk. So all of this rather scary stuff. And this is the kind of, unfortunately, these are always the papers that get published in the media. You've probably never seen any of my papers published in the media because I rarely find anything really wrong when I'm studying antidepressants in pregnancy. But people that find, statistically significant results for adverse effects will always get picked up in the media. It's more interesting. So anyway, so all this bad stuff, and you think, oh my goodness, this is very bad. So anyway, so the authors reported that benzodiazepines were highly associated with an increased risk of preterm delivery. But then when I looked, this is when I absolutely read the paper. So this is an abstract that I would not just read the abstract. I'd go and read the whole thing, every word. There was only 85 women out of those 3,000. Remember, it said there was 3,000 pregnant women. 85 took benzos. And then they said this, so it made it look like the whole cohort were taking psychotropic drugs. But when I look closer, only 10% were, 300 out of 3,000. And in addition, they categorize hydroxyzine, which is a very old antihistamine. It's not really a psychotropic drug. It's used for, allergies and rashes in pregnancy. Anyway, 107 took that. So we got down to a pretty small sample size in the end. So the sample size they had, there's no way they could have been saying given all the information that they said. So does that make sense to everybody? And here's another one. I give this an example because this is published in the New England Journal. And the author's a friend of mine, so I don't want to think I'm nothing against her. But the problem is, this is another one that really reached the media and the population and really frightened women who were taking antidepressants. And this wasn't even my colleague's decision to write this in the abstract. She did not write this. The journal wanted her to put it this way. This is why there's many ways of writing results. You can, I think you've probably all heard the theory that the glass is half full or the glass is half empty. And half full is much more positive, isn't it, than the glass that's half empty. And I think it's the way you describe it. So yes, there was an odds ratio of 6.1, but they didn't really tell you how many there were in the study. For instance, if you have a study with 1 million people here and 1 million people there, and this 1 million people had twice as much the adverse effects, you would have an odds ratio of 2. However, it would still be only 2 in 1 million. So does that make sense? So this is the kind of way that people twist it, and the journal wanted her to put that. But what she wrote in the text, which actually came from her, as you can see at the end, isn't this a lot more reassuring? So in other terms, about 99% of these women would not deliver a baby with PPHN. So that's just another example. And then the validity of results. This is another paper where the authors found an increased risk for malformations. In this one, there was no pattern of defects. To say something is a teratogen, they have to have the same defect. All the babies have to have the same defect. They can't be all different ones. And you can't put major and minor malformations together. It doesn't. And this is another prescription event monitoring program. These prescription, they have huge numbers, these databases, but you don't actually know if the woman took the drug. So what happens is the pharmacist dispenses the drug to the woman, and it gets sent to this computer events monitoring system, but you don't actually know if the woman went home and took it. And my husband used to be a pharmacist, and he told me, he said he knew people that used to bring a prescription, fill a prescription every month, and they never took it, but they still got another one. And so this is human nature, and we don't have any control over human nature, and that's one of the exciting but difficult things about observational research. And also, especially with psychiatric patients, they frequently use other drugs, and they smoke more, they drink more alcohol, so a lot of these things you don't know. And here's another quick one. Look, this is looking at something that's statistically significant but not clinically. So in this one, the authors found 30 grams difference in birth weight. So they said, there was an increased risk for low birth weight. Well, the average weight of a newborn baby is about 3,500 grams. So I don't think I'd be too worried if my baby was 30 grams. My baby was 3,400 grams. So again, this is what happens when people don't really understand the difference between statistical significance and clinical importance. That's another message I really want you to take home. And this is another one saying, we already know that there is a chance of having abrupt withdrawal symptoms after having a baby's born because they're not exposed to the antidepressant anymore. So we already know that, but we would have liked to know in this paper how often does this occur. Giving us an odds ratio doesn't really help any because we already know this occurs in about 15% of the times it occurs. So this was a different kind of a situation. And then here's an example of meta-analysis. And for some reason they didn't include my paper, and I think because they wrote to me and I didn't really have anything to add, so they didn't include my paper. So it changed quite a bit because I had 1,100 cases in my paper. So it's all, it's all very interesting. And then bias, here's one last one. This is a huge example of bias. So these authors, and this is another paper that got published in and the internet and everywhere, the newspapers everywhere, and antidepressants, there's all these bad things. However, the authors only picked out, it was called a systematic review, which means you're supposed to get all the literature and put it all together. You don't miss any, you don't pick and choose what you want to include. And all they included was studies that found something wrong. I can assure you there was not one single one of my studies in this review, which is ridiculous, being as I've published about 20. So I was a bit annoyed about this one. Not because my study wasn't included, but because they just only picked what they wanted to pick. So anyway, so the main thing I want to tell you is that every study, the observational research is not perfect, and I know that, and I would never try and say that it was. But then they all have limitations, and authors don't always tell you everything in their study. So all I'm asking you to, next time you read a paper, just read it a little bit more carefully and say, does that make sense? And also we always think, because it's published in the New England Journal, oh, it must be great. Or if it's some famous author, well, he must know what he's doing. So we need to, I just ask you to think really, really carefully next time you read a paper that you've downloaded. And this is what we have right now, and my colleague here already mentioned about the FDA. And actually the FDA now has adopted what we've been doing at Mother Risk for 30 years already, the narrative form. Because every patient is individual. You cannot have categories that there's just no way. You have to treat every single patient as an individual. So every woman who has a psychiatric disorder, some may need drugs, some may not. Some ECT may work, but I don't believe there's any one way of treating her. But I think my point of view is that you have to know the basis behind all the research and what it all means, instead of just reading what they want you to read in the abstract or in the internet or whatever. So we'll see what happens to this. This has been going on. I've been to at least 10 meetings about this, and it started about 15 years ago, and that's how long. Governments, especially in the US, governments take a very long time for changes.
Do you think you can conclude in 5 minutes?
Oh yes, okay. I'm pretty much done. So, yeah, I just got 2 more slides, I think. I'm just going through, these are the information that you can. Anybody could have these slides anyway if they want them, right? If somebody wants my slides. And so these is just the information. And so there is a lot of, I'm giving you these, so people say, oh, well, there's not any information. Well, there really is. There's a lot of places you can go to get information all over the world. And so my bottom line, so anyway, as I mentioned before, that this is really important, and I hope that it does become important in Turkey, because I think knowledge transfer, translation is a really important field. I really believe in it. That's why I did my PhD dissertation on it, because I think it's so important. And so, because we know, and everybody knows, that pregnancy and drugs is a very sensitive situation, very complex, and women and their healthcare providers are highly impacted by the information that they get. So it's up to us as healthcare providers to give them the best evidence-based information that there is, so they can make a proper informed decision. And, oh yeah, this is a survey that I did. We can leave that. So I think this is like my last slide. So obviously, as I mentioned already, it's not likely in the near future that pregnant women will be included in randomized controlled trials. And all of the methods have some deficiencies in study design. However, it doesn't mean that we cannot use this information. And my retort to my colleague is, I don't think there's we should have a position where you should only use this or only use this. Personally, my personal opinion is that to treat pregnant women with psychiatry, it's already tough being pregnant, and when you have a psychiatric disorder, it makes it even harder, especially because there's still so much stigma. Even though we're 2015, there's still stigma about mental illness, and women need to be treated. And I think we should use everything that we have in our arsenal to treat them. So that can include ECT, it can include drugs, and also psychotherapy. So for me, I think we should combine whatever works for each individual woman, so she's be able to have a nice pregnancy and not worry all the time, like a lot of these women do. So I guess that's it. Thank you.
Thank you.